Hey everyone, welcome back to PodBites, where we break down complex medical topics into bite sized pieces, perfect for your commute, coffee break, or whenever curiosity calls. I'm Yusuf Mushtaha, your host for today's episode, and I'm joined by Yusuf Shimy. And today we're diving into something that every medical student and doctor encounters, that is, joint pain. From the creaky knees of an old gardener to the fiery red toe of a gout attack, every joint tells a story.
All right. Hello, everyone. Joint diseases are a universe of their own. Some are slow and silent, others are sudden and destructive. Our goal today is to trace that spectrum, from degeneration to immunity to infection, and help you recognize how one simple complaint, Doc, my joint hurts, can mean so many different things.
So before we get to the cases, let's lay the foundation. What are joints, and how does knowing that relate to its clinical implications?
A joint is where two bones meet, and they come in different types. But the most clinically important are synovial joints. They are freely movable and lined by a delicate synovial membrane that produces synovial fluid, a clear viscous fluid that nourishes cartilage and allows bones to glide smoothly.
So cartilage has no blood supply of its own. Synovial fluid is its lifeline.
Right. And when the system gets disrupted by wear, autoimmunity, or infection, that's when arthritis appears.
So arthritis isn't just one disease. How do we sort through all of them?
We divide joint diseases into four broad families. First, the degenerative. Think of osteoarthritis, where cartilage simply wears out. Then, the inflammatory, where the immune system attacks the joint, like rheumatoid arthritis or the seronegative spondyloarthropathies. Next, the infectious, like septic arthritis, where bacteria invade directly. And finally, the hemorrhagic, where bleeding fills the joint, like in hemophilia or trauma. And we're going to discuss each of them one by one.
And clinically, that classification shows up right from the start. A single red joint. That's monoarthritis. A few joint, oligoarthritis. Many joints, polyarthritis.
Exactly. It's our roadmap even before ordering labs.
Alrighty, Shimi. So when a patient walks in with joint pain, where does your mind go? And how do you go about your investigations?
Most importantly to start with is the onset. Acute pain points toward infection or crystals, while chronic pain suggests degeneration or autoimmunity. Then, symmetry. Bilateral joints hint at systemic inflammation. Because if the whole body was under attack, it wouldn't just target a single joint and leave the other. Whereas if it's on one side only, this points us towards local causes like infection or trauma.
That's a lot of clues from just knowing the timeline and location.
And stiffness gives another clue. Stiffness that lasts under 30 minutes fits degeneration, while over an hour screams inflammation.
Okay, so this is all information we can gather from history. What about on physical examination? Any important clues there?
Absolutely. We inspect for swelling, warmth, and deformity, and we palpate for tenderness and effusion. We also can't forget about assessing for range of motion. We do this by moving the joint both actively and passively to check for range and pain.
And there are certain signs that are extreme red flags, like when a joint is hot and swollen. There is no time for guessing. We aspirate.
Perfect segue into what I wanted to discuss next: synovial fluid aspiration.
That's one test that really tells a story.
Definitely. So, normal fluid is clear, viscous, and nearly cell free. In degenerative joint diseases like osteoarthritis, it's still clear, but slightly increased in volume. Meanwhile, in inflammatory arthritis, it turns cloudy, thick, with white cells. And in septic arthritis, it's opaque yellow green, full of neutrophils, and culture positive. Finally, in hemorrhagic arthritis, it's bloody, obviously, but sterile.
So just by looking at that aspirate, you can already narrow it down.
Definitely, it's the diagnostic compass for any arthritis.
Okay, now that we've got our bearings, structure, classification, and approach, it's time to bring the cases to life.
Let's begin with the one that shows up in every clinic: the slow grinding wear of osteoarthritis.
Alright, let's take a look at this patient. A 65-year-old woman complains of knee pain that worsens throughout the day. She's overweight, loves gardening, and says mornings aren't too bad. But by evening, she's limping.
That's classic osteoarthritis, a degenerative joint disease, not autoimmune. The cartilage gradually breaks down, the joint space narrows, and the bones try to overcompensate with new growth. Those are osteophytes.
And this is what you see on X-ray, the famous SUNS, which stands for subchondral sclerosis, osteophytes, narrowing, and subchondral cysts.
Correct. The joint isn't inflamed, it's mechanically fatigued. Synovial fluid stays non inflammatory, and WBCs are low. And over time, patients develop Heberden's nodes at the distal interphalangeal joints and Bouchard's nodes at the proximal interphalangeal joints. Remember, B comes before H, and proximal comes before distal.
So primary osteoarthritis is just age-related wear and tear. Secondary comes from trauma or obesity.
Indeed. And sometimes, even altered gene expression like RUNX2 contributes to abnormal bone remodeling.
Oh, I see. And what is the treatment?
We start with lifestyle changes, things like weight loss and low impact exercise. After that comes pain control, usually acetaminophen or NSAIDs. If the symptoms still don't settle, we move on to intra-articular steroid injections. And when all conservative options fail, arthroplasty becomes the final step.
Got it. Thank you, Shimy. Now that we've got this covered, let's move to joints destroyed not by time, but by the body itself. A 42-year-old woman comes with painful, swollen hands and morning stiffness that lasts an hour. Her joints feel better as the day goes on.
Sounds like rheumatoid arthritis, the most common inflammatory joint disease we see. It affects about 1 to 2% of people, and for reasons we still don't fully understand, women get hit 2 to 3 times more than men. It targets the synovium, forming a pannus, which is the granulation tissue that invades cartilage and bone.
Rheumatoid arthritis really doesn't play around. Higher morbidity, even early mortality in severe cases.
Exactly, especially when the inflammation stays active. And almost 40% of patients develop extra-articular disease, usually those with high rheumatoid factor titers.
And it's driven by immune chaos, right?
Absolutely right. Rheumatoid arthritis is basically an immune system meltdown inside the synovium. Autoantibodies like rheumatoid factor and anti-CCP build the hype. Cytokines like TNF, interleukin 1, and interleukin 6, even interleukin 2 and interferon gamma, fan the flames. And the pannus forms, that aggressive granulation tissue that eats cartilage, bone, ligaments, everything.
And that's how you get those textbook deformities. Swan neck, boutonnieres, ulnar deviation.
True, but rheumatoid arthritis is not just a joint disease. It's systemic. The same inflammation that breaks down joints travels everywhere. It affects the lungs, heart, eyes, blood, and nerves. Think pleuritis, pericarditis, scleritis, anemia, and even C1-C2 subluxation.
Alright, how do we diagnose this whole spectrum?
We use the ACR-EULAR criteria, which assesses small symmetric joint involvement, morning stiffness, rheumatoid factor and anti-CCP positivity, ESR-CRP elevation, and radiographic erosions.
And what about the management?
Management is layered. We start with NSAIDs for pain, then move to DMARDs like methotrexate as first line, sometimes combined with hydroxychloroquine or sulfasalazine if needed. If that's not enough, we escalate to biologic agents, such as anti-TNF drugs or rituximab. More recently, JAK inhibitors like tofacitinib are being used, but only after screening for TB, hepatitis B, and ensuring the patient is vaccinated for shingles.
Alrighty, Shimy, let's move on from one autoimmune storm to another. But this next group doesn't play by the same rules.
Oh yeah, the seronegatives. They are called that because they lack rheumatoid factors and anti-CCP, but they are still inflammatory and often linked to HLA-B27. And the easiest way to remember them, the mnemonic PEAR.
Exactly. P for psoriatic arthritis, E for enteropathic arthritis, A for ankylosing spondylitis, and R for reactive arthritis. 4 diseases, all seronegative, all HLA-B27 associated, and all targeting the spine or sacroiliac joints. Let's start with ankylosing spondylitis.
Inflammation starts at the sacroiliac joints and ascends the spine. Over time, the vertebra fuse. That's the bamboo spine on X-ray. Patients usually wake up stiff, but their symptoms improve with movement, not with rest.
And beyond the spine,
it can affect the eyes, causing anterior uveitis, heart as an aortitis or AV block, lungs by apical fibrosis, and kidneys, causing IgA nephropathy.
Then comes reactive arthritis, formerly Reiter's.
Right. It's post-infectious, triggered by GI or GU infections like chlamydia, salmonella, or Shigella. And a good way to remember the main symptoms is the classic phrase, can't see, can't pee, can't climb a tree. It presents with the triad conjunctivitis, urethritis, and arthritis, plus skin signs like balanitis circinata and keratoderma blennoragicum.
And finally, enteropathic arthritis ties to inflammatory bowel disease, Crohn's or ulcerative colitis.
Correct. Treat the IBD and the arthritis improves.
So, we've seen degenerative wear, autoimmune chaos, and systemic inflammation. But inflammation doesn't always need antibodies. Sometimes it's caused by something much smaller. Next up, we meet a 50-year-old man who treated himself to a juicy steak last night. And this morning wakes up to a throbbing, fiery red big toe that's so sensitive even a bed sheet feels like torture.
That's the classic presentation for gout, a condition that often masquerades as other causes of acute arthritis and is the most common inflammatory arthritis in men. It's caused by monosodium urate crystal deposition from hyperuricemia.
And hyperuricemia can come from producing too much or excreting too little.
That's completely true. Overproduction happens in tumors or lymphomas, and underexcretion happens in chronic kidney disease. Add alcohol, red meat, and drugs like aspirin or thiazides, and you have the perfect storm.
Yikes, that does sound painful. And the attacks are sudden, often monoarticular, and fade away, only to return later.
And it's important to remember that serum uric acid can actually be normal during an acute attack, because inflammation can push uric acid into the tissues. That's why we recheck levels once the flare has settled.
Oh, I see. And what can we observe on joint aspiration?
Joint aspiration shows needle-shaped monosodium urate crystals, a high WBC count with neutrophil predominance, and a steroid culture, which helps distinguish it from septic arthritis. Under polarized light microscopy, these crystals are negatively bifringent, appearing yellow when aligned parallel to the compensator and blue when perpendicular. And if you can't aspirate the big toe, you can try the ankle or the knee instead, since these joints are easier to tap and may still contain diagnostic crystals.
Got it. And treatment starts with pain control like NSAIDs or colchicine. We never start allopurinol during a flare.
Spot on. Allopurinol comes after symptoms resolve, usually 300 milligrams daily, alongside lifestyle changes like cutting red meat and alcohol.
Perfect. All clear now. Moving on to our next condition, gout's cousin, which doesn't use uric acid crystals, instead uses calcium.
That's pseudogout, also known as calcium pyrophosphate deposition disease. It mimics gout, but usually affects older adults, often targeting large joints like the knee. The attacks can be just as painful, but the pattern and the age of the patient help us tell it apart from gout.
Another important point of differentiation is that joint aspiration here shows rhomboid crystals with positive birefringence.
That's the idea. Under polarized light microscopy, CPPD crystals are positively bifringent, meaning they appear blue when aligned parallel to the compensator and yellow when perpendicular, which is the complete opposite of gout. Synovial fluid also shows an elevated WBC count, but the cultures remain sterile, helping us distinguish it from septic arthritis. Moving on to imaging. X-rays may show chondrocalcinosis, meaning calcification of the cartilage, a classic clue.
And what about treatment here?
Treatment focuses on controlling symptoms with NSAIDs, colchicine, or corticosteroids, depending on the patient's comorbidities. You can also check for underlying metabolic causes like hemochromatosis, hyperparathyroidism, hypomagnesemia, or hypothyroidism, because correcting these can help reduce recurrences.
Alright, now moving from crystals to bleeding. What if the joint looks swollen, but it's full of blood, not pus or urate?
That's hemarthrosis, or hemorrhagic arthritis. It usually happens in hemophilia or after trauma.
And what about the aspirate?
Fresh blood. Sterile, not purulent. Repeated bleeds, especially in hemophilia, gradually destroy cartilage over time, leading to secondary osteoarthritis.
So it's not infection or inflammation, it's mechanical damage from inside the joint itself.
Exactly. And the fix is addressing the cause. Replace the missing clotting factor or rest the joint if traumatic.
Ooh, makes sense. But if a joint is hot and painful and the patient has a fever, that's not blood anymore. That's infection knocking on the door.
And that leads us to our next segment.
Alrighty, Shimy, let's start this one with a bang. Because this next case is the kind you cannot afford to miss. A 60-year-old man shows up to the ER with excruciating pain in his left knee. He says the pain started suddenly yesterday but got dramatically worse overnight. The joint is hot, red, and massively swollen. He can't bear weight. His temperature is 38.7 degrees Celsius, and he looks genuinely uncomfortable, sweating, irritable, and guarding the leg. You try to move the knee even a few millimeters, and he nearly jumps off the stretcher. He has diabetes, a history of osteoarthritis in that same knee, and just finished a course of steroids for a COPD flare 2 weeks ago. Shimi, what's the first thing this screams to you?
This is classic septic arthritis, the most dangerous arthritis on the list, and a true orthopedic emergency, one you can't afford to miss. If not drained, the infection can eat through cartilage and bone within hours.
Alright, walk us through it. What exactly is happening in that joint?
Good question. Bacteria invade the synovial membrane, usually Staphylococcus aureus, which is responsible for almost half of all cases. Gram negatives make up about 10%, especially in IV drug users. Septic arthritis is usually monoarticular, commonly affecting the knee or hip, and impacts infants and elderly the most.
And what are some of the risk factors that can predispose someone to getting septic arthritis?
Any pre existing joint disease, like rheumatoid arthritis, osteoarthritis, gout, or prosthetics. These increase the risk. Other factors include diabetics, immunosuppression, IV drug use, or skin ulcers. One thing to notice is that joints affected by rheumatoid arthritis usually have the worst outcomes.
And how does the infection actually reach the joint?
Most often through the bloodstream, but it can also spread from nearby infections, enter through trauma, or even after joint injections or surgery.
Oh, I see. So once the bacteria get in, what happens? How do we get all of these symptoms?
The bacteria stick to the membrane and release toxins, like toxic shock syndrome toxin 1, or TSST1, and alpha hemolysin. In response, the immune system floods the joint with neutrophils and cytokines. As a result, pressure builds, blood flow drops, cartilage dies.
Sounds pretty intense.
Yep, and if left untreated, the infection spreads to bone. That's when it becomes osteomyelitis.
And clinically, it's hard to miss. Severe pain, redness, swelling, and fever.
Without a doubt, the joint becomes exquisitely tender. The patient won't let you even touch it. In kids, it's often the hip, while in adults, the knee. In IV drug users, think sternoclavicular or sacroiliac joints.
Noted. Oh, there's also a gonococcal variant, right?
Yes, in sexually active young women, it's part of disseminated gonococcal infection with the triad migratory polyarthritis, dermatitis, and tenosynovitis. It's usually milder and rarely fatal.
So how do we diagnose septic arthritis?
We start with the blood work. It usually shows elevated WBC, ESR, and CRP. Next, blood cultures, but they should be taken before antibiotics. These are positive in almost half of the cases. However, the key to diagnosing septic arthritis, it is joint aspiration. This shows WBCs often over 100,000, with more than 75% being neutrophils, an opaque yellow-green fluid with low viscosity, and a positive culture. There are no crystals, so gout can be ruled out. Imaging typically goes from X-ray to CT to MRI or ultrasound to assess effusion and cartilage damage.
Considering the severity of these symptoms and its potential complications, management must be extremely time sensitive. Tell us about it.
For management, you need to drain immediately using arthrocentesis or arthroscopic lavage within about 10 hours. Then, IV antibiotics, immobilization, and pain relief. And always remember the golden line: if you don't drain, you destroy.
I'll definitely keep that in mind. Does it have a high mortality rate though?
Up to 50% with Staph aureus, but almost none for gonococcal infections.
Alright, got it. Okay, Shimi. Now let's see what we remember with a rapid fire quiz.
Go ahead.
Most common root.
Hematogenous.
Most common joint involved in kids versus the most common in adults.
Hip in children, knee in adults.
What triad defines gonococcal arthritis?
Alright, I think it is migratory arthritis, dermatitis, and tenosynovitis.
And finally, the key to saving the joint.
Drain fast! Cartilage death starts in hours!
Amazing. I sure hope the listeners were able to keep up. So what happens if you don't catch septic arthritis in time?
Then, the infection breaks through the cartilage and reaches bone. That's osteomyelitis. It's not a new disease, it's just septic arthritis that's been left to deepen. The pressure and pus destroy cartilage, reduce blood flow, and let bacteria invade the subchondral bone.
So, in other words, every untreated septic joint becomes an infected bone.
Exactly. That's why early drainage saves both the joint and the bone beneath it.
Alright, time to tie it all together. This was a long journey.
Indeed, it was a long one. We started with osteoarthritis, the wear and tear disease, a non inflammatory condition that worsens with use. X ray shows suns, and the synovial fluid stays clear.
Then we covered rheumatoid arthritis, an autoimmune disease that hits joints symmetrically, causes morning stiffness lasting over an hour, leads to characteristic deformities, and is famously anti-CCP positive, with multiple possible systemic manifestations.
After that, the seronegative spondyloarthropathies, which are rheumatoid factor negative and are linked to HLA-B27, involving the spine and sacroiliac joints. Ankylosing spondylitis stiffens the spine into that classic bamboo spine appearance. Reactive arthritis is triggered by prior infections, and enteropathic arthritis develops in the setting of IBD.
Next were the crystal arthropathies. Gout with monosodium urate, needle-shaped crystals linked with red meat and alcohol, treated with NSAIDs, colchicine, and allopurinol after remission. Pseudogout with calcium pyrophosphate, rhomboid-positive crystals and chondrocalcinosis involving the large joints.
Then, hemorrhagic arthritis, which is bleeding into the joint from hemophilia or trauma, showing fresh blood on aspiration, leading to secondary osteoarthritis over time.
And finally, the most urgent, septic arthritis, a monoarticular, mostly Staph aureus, presenting with fever, pain, swelling, high WBC in fluid, and needing immediate drainage and IV antibiotics. And if you wait too long, that septic joint becomes an osteomyelitic bone.
Absolutely. From mechanical damage to autoimmune destruction, from crystals to bacteria, we've covered the full spectrum of arthritis.
Okay, Shimy, that rapid fire was kind of fun. Let's do another quick one before we wrap up. Osteoarthritis. Is the pain worse with use or rest?
It's gotta be with use.
Rheumatoid arthritis. Tell me about the duration of the stiffness.
Of course, over 1 hour.
Gout. Crystal shape.
Needle shaped.
Pseudogout birefringence.
Positive birefringence.
Septic arthritis first step.
Aspirate, then drain.
And this wraps up today's episode of PodBites. From wear to warfare. From simple stiffness to surgical emergencies, joint pain may start the same way in every patient, but understanding its nature is what saves movement and sometimes lives.
Thanks for tuning in. And remember, every joint has a story. Listen carefully, and it will tell you what's wrong.
This is PodBites, where learning moves with you. Until next time, bye-bye.
Plus, skin signs like balanitis cercinata and keratoderma blenor.
عادي بعدين هدي شوي عادي.
Okay. Plus, skin signs like balanitis cercinata.
خلاص قول اللي بترتاح عليه. مصر ما
Add alcohol, red meat, and drugs like aspirin or thiazides, and you have the perfect storm.
Yikes. يا اسمع عيد فرق انت عشان تطلع طبيعيه.
Okay.
اخر شوي.
However, the key to diagnosing septic arthritis, it is joint aspiration. This choice. Yeah, stop.
هاي خليها imagine.
Like, wait. And Staph aureus is coming. Staph aureus is coming.
Staph aureus. Most common organism.
Staph aura. I mean Staph aureus. But I need to hear it. I have to hear it. Stop it.
This was a long journey.
Yeah. خليها برضه. ما هو this was a long journey I need to يعني على طول we started with osteoarthritis ومش عارف ايه. Yeah بس كده. Yeah. Definitely.
لا مش
Yeah.
Definitely, absolutely.
Absolutely. Yeah.
Yeah,
I get you. بس yeah, I get you.
هو ما في ايش I get you. انا ما حكيت ايش.
It was a long journey, I get you.
ما في شيء.
يعني it was a long journey. Indeed it was. Indeed. اتفق. I agree. High five.
All right, time to tie it all together. This was a long journey.
I agree with you. هاي أسوأ واحدة.
I agree with you. Until next time, bye-bye.
أخيراً.
No.